our PGTs will present 7 interesting cases. So we can have discussion after they present each of the cases. So first case will be presented by Dr. Naushad Akram Ansari. So I request him to come here. The case is acute flaccid paralysis, not the usual suspect. So please come and start the presentation.
I have a question. If we don't ask, judges can ask.
Yes, ma'am. Definitely after they finish, so that we can. No. After each case. After each case.
Good afternoon, respected guests, professors, and my colleagues. I, Dr. Naushad Akram Ansari, am going to present an unusual case of acute flaccid paralysis. It's a 12-year-old male child admitted on 20th of December with complaints of progressive weakness of both lower limbs for last 7 days, for difficulty in walking and standing without support for last 4 days, had an history of high-grade fever for 4 days, was restricted to bed and difficulty in passing urine for stool for last 2 days. No history of any convulsion, altered sensorium, or difficulty in vision. No history of any trauma or vaccinations, or no history of similar illness in the family or in the past. But there was a viral fever-like illness 3 weeks back, lasted for 3 days. This patient on examination is bed-bound, not able to move the lower limbs, but able to move the upper limbs. Patient is legs are externally rotated. Vitals are stable. Single breath count 27 with no respiratory distress. Higher functions were normal. Fundoscopy is normal. Cerebral signs absent. On motor examinations, lower limbs, the bilateral semical bulk with decreased tone, flaccid, power of 1/5 grade. Knee jerks were present, while ankle jerks were not elicited. However, the upper limbs were completely normal of bulk, tone, and power. Plantar reflex were equivocal. There was diminished tension below T6 segmental level. The bladder were distended with retention, overflow, continence. Superficial reflex, abdominal and cremastic reflex not present, but anal were diminished. So to summarize this case, a 12-year-old boy with complaint with a history of bilateral lower limb weakness with urinary retention, with conscious no altered sensorium, with sensory deficit below T6 level, with absent superficial and ankle jerks, with no cranial nerve deficit or upper limb weakness. So differential diagnosis at this point is myelopathy, non-compressive, transverse myelitis, compressive, or other demyelinating disease like NMO, MOG spectrum, MS, CIS, ADEM, or GBS. So it could be a different in the differential diagnosis. It could be polio. We did the routine blood investigations which were within normal limits. We did the MRI dorsal lumbar spine with the screening of the cervical spine, which shows patchy intramedullary hyperintensities into the cervical cord with extending the dorsal spinal cord. We also did a MRI brain screening, which shows the confluent hyperintensities in the subcortical and periventricular white matter and internal capsules. However, the optic nerves were normal. We did a CSF study which shows CSF pleocytosis with protein of 45 with mononuclear predominance. CSF for multiple sclerosis panel was done, which shows the IgG of 74 with oligoclonal brands were present. We did a serum NMO and anti-MOG blood, which were negative. Eye checkup and VP was normal. So at present, this diagnosis stands as clinically isolated syndrome presented like a case of acute transverse myelitis. we gave initial treated with pulse intravenous methylprednisolone for 5 days at the rate of 30 milligram per kg per day, followed by oral prednisolone in tapering doses with supportive treatment. Patient responded well to IV methylprednisolone, could sit with support in 3 days, could stand with support in 7 days, but could not walk independently. So we discharged the patient on wheelchair and patient was on catheter. Repeat MRI brain and cervical spine was done after 3 weeks, which shows regressions of the demyelinating lesions. Clinical isolate syndrome is the first acute episode of clinical symptoms referred to any central nervous system sites with presumed inflammatory demyelinating etiology with no previous history of any central demyelinating event. Examples are optic neuritis, transverse myelitis, or neurologic symptoms and signs due to brainstem or other sites. Transverse myelitis can present as independent entirety as post-viral infections or continuum of neuroinflammatory disorders like ADEM, MS, MOGAD, NMOSD. On follow-up, after 1 month, this patient was able to walk independently without any lower limb weakness, without any truncal weakness. So what we have learned from this case is CNS demyelination may be extensive radiologically, but without obvious corresponding clinical management also. So MRI of the level of lesion suggested by clinical picture as well as screening of other sites should be done for complete diagnosis and management. Thank you.
On the penetration, it was it's a transverse myelitis. I only have some suspicion why it was labeled as a poliomyelitis in the beginning. Bilateral symmetrical paralysis. Poliomyelitis should be coming.
Presentation.
But it can be symmetrical.
There are four.
It is symmetrical, but
Only asymmetrical.
differentials.
That's a very important thing.
The other way around also we have seen the operant was initially very asymmetric. And then within a few days it became symmetric. So initially আমরা যখন asymmetric ডক্টর বলে পুরো একটা asymmetric জিবির মতো হলো আমাদের তারপরে দেখা গেল যে জিবি হয়ে দাঁড়ায় initially it was a asymmetric. So unlike in the আমরা ভাবছিলাম জিবি but then ultimately
I think the point is that when you show that this you could also see pros and cons. Why you are probable diagnosis and then show your investigations. And then you come into
Non-syllable.
that is
We acute because the symptoms and signs we think of into a ADEM-like picture because it's complaint. It's a spectrum. It covers the spectrum of this demyelinating disorders. So we thought of that, but initially after the investigation we ruled out the other person.
TNS changes আছে anapod changes আছে
Many cases of myelitis decay that present because they are just determined the future treatment. Here also, since the patient is having asymptomatic radiological isolated syndrome, not physically that is evident, and maybe this patient will be on some RNS if there is an relapse and determining the further treatment, whether it is or any other treatments. Because nowadays so many treatments are available. CB is positive. There are many criteria not taking that, but there are definitely programs where what should that we should all do the screening of them because later on it is that conflict each so loss of sensorium and then some data different investigations here at least one sees agree with comes, the part that's not coming. That's
Thank you.
আমাদের without keeping white matter and gray matter coming very difficult. All this a spectrum of matter.
चाहते हो that
Lot of echo. Let us speak one by one. So thank you, Naushad, for opening the session. Now we move on to our next case. A floppy baby, blame it on the rods. It will be presented by Dr. Kushal. Dr. Kushal Banerjee.
So, good afternoon, everyone. I am Dr. Kushal Banerjee. Good afternoon, everyone. I am Dr. Kushal Banerjee. I am going to present a case of floppy baby. So, a 5-day-old male baby presented in our ER, born out of non-consanguineous marriage, having history of respiratory distress, lethargy, and feeding difficulties. He had a history of decreased fetal movement in antenatal period, and there is history of delayed cry after birth and history of meconium stain liquor. Mother had hypothyroidism. So on examination, the baby was tachycardic, the CRT was normal, the baby was tachypneic with subcostal distractions. Side change.
Don't touch. Don't touch.
কত বয়স ছিল বাচ্চা
5 days.
166 এর condition.
Mild type. Baby having frog leg posture, the cry tone reflex were depressed. The baby on examination showed a high arch palate with bilateral undescended testes. There is no obvious dysmorphism. On admission, we found that the initial blood gas showed respiratory acidosis. So we put the baby on CPAP. The baby was euglycemic. We started IV fluids and empirical antibiotics. The nasogastric tube feeding was started, and we sent all the routine investigations. Initial investigation showed the complete blood count was normal. The CRP was 2 times higher than the normal limit. Chest X-ray showed no cardiomegaly, no pneumonic changes. The liver and the kidney function tests were normal. The thyroid function test was also normal. The blood and urine culture, which were sent, revealed no growth. As the baby having feeding difficulties and lethargy, so we did a lumbar puncture, which came as normal, and brain imaging shows no obvious abnormality. So to sum up, the baby having hypotonia, respiratory distress, and feeding difficulties. So what could be the possibilities? It may be the sepsis or meningitis, which were ruled out by blood and urine culture and the lumbar puncture. It may be due to hypoxic ischemic encephalopathy or structural brain disease, which were ruled out by neuroimaging. In view of inborn metabolism, we sent lactate, plasma lactate, and plasma ammonia, which came as normal, and we also sent the IEM panel, which came as normal later. There was no as such characteristic clinical finding indicating chromosomal disorders. So not only by the investigation, also clinically we ruled out the central hypotonia by the gradually improving look of the child. There's no fisting of hands, and there's no seizure episodes.
there was difficulties in weaning off from CPAP, and the persistent generalized hypotonia as evident by 180-degree flip test. So we thought about peripheral hypotonia. So as we are thinking about peripheral hypotonia, we should evaluate the clause systematically. So for anterior horn cell disease, there may be spinal muscular atrophy, but there is no tongue fasciculation. In SMA type 0, it may be present in this early age group, but there was arthrogryposis, which are not seen in our cases. For nerve disorders, there may be hereditary motosensory neuropathy, but it is very difficult to assess clinically. For neuromuscular junction disorder, there is congenital myasthenic syndrome and transient neonatal myasthenia, but there is no history of maternal myasthenia, or there is no diurnal variation of the weakness. For muscle disorder, there is congenital myopathy and congenital muscular dystrophy, but these two are very difficult to distinguish clinically. So we performed further investigations. We did serum creatinine kinase level, which were normal, and performed the whole exome sequencing, which report came as nemaline myopathy 2 due to NEB gene mutation, that is nebulin gene mutation. So there was no as such treatment. The treatment was only supportive. The baby was put off on CPAP and weaned off gradually and discharged with feeding through NG tube. On follow-up, the nasogastric tube was removed by 3 months of age. The child was feeding orally and gaining weight slowly. At the age of 4 months, we can see that the baby having slender muscle mass and dolichocephaly. So few lines about the disease. Congenital myopathy refers to muscle disorders characterized by onset in early life with hypotonia, hyporeflexia, generalized weakness. The proximal involvement is much more than the distal. The poor muscle bulk and associated with dysmorphic features. Among the many types, nemaline myopathy is most common. There may be mutation in around more than 10 genes like ACTI1, TPM2, NEB gene, which is seen in our case. There may be autosomal dominant and autosomal recessive inheritance. It may be classified in 3 major forms: severe neonatal and infantile form, juvenile form, and adult onset form. For NEB gene-related myopathy, which is most common among all the nemaline myopathies, the axial and bulbar involvement is much more commoner than the limb weakness. And in our case, we saw that our child having feeding difficulties, so there is bulbar weakness is prominent. The baby can survive up to 1 year of age. So what is our take-home message? In a floppy baby with respiratory distress and feeding difficulties, we should think beyond sepsis and CNS causes. Congenital myopathy, though rare, we should be kept in mind in such situations as an important cause of peripheral hypotonia. Genetic study is very important, not only to place the diagnosis, but also for future pregnancy. We should counsel the parents regarding the future pregnancy. Thank you.
Before any at the leaves, I mean, the leaves are very thin and facile. And because of this, there is no muscle food. The ribs are not thick that you see normally. That's very characteristic in any congenital myopathy. That the ribs look very thin and facile. That's the language we offer. That very thin. So there is no muscle. There also the ribs are thick, but it's very relative. One can be very definite on that. But it is likely to be thin because the muscles are not strong.
Reflexes. Yes, yes.
You think of
Yes.
Reflexes are dominant.
you think of transmission.
Yes, actually, the child had bilateral descendant and undescendant testes, and but there was no as such clinical findings like facial. There was no
I think we will get almost 7% of the cases of hypotonia for ultimately turns out that it's one of the most common cause. And this big means I know that brother will is Dr. Nara, তখন বোঝা যাবে তখন বোঝা যাবে but one of the important cause of hypotonia in newborn 7% cases is due to pregnancy.
Very center must go and.
Autosomal recessive.
So any concern?
No concern in that.
And what about next? Next pregnancy?
So genetic study করতে
What points? The
আমার
parents
করতে হবে what counseling পুরোটা কি দাঁড়া
মানে পরে next pregnancy আগে মানে
they will take another pregnancy হবে না
yes.
The prognosis in these babies is uniformly poor. By all support, yes. So this baby will not survive most likely beyond
Up to 1
1
year
and a
of
half
age.
years. So if we know the mutations, we can look for the bone mutation or any other mutation. And antenatal diagnosis most of the time is offered in other countries. We are still lagging behind because but
No, we can
nowadays
can-
nowadays we are having the genetic
We
test
can do from the mother's blood test also now.
and these whole exam comes at a cost of around 18,000.
but they won't baby or they will adopt and
No. We can now do pregnancy day. We can do feed test during the pregnancy. Fetal cells in 6 to 10 weeks.
and
We
about
can
the
do the chorionic sampling at around 10 to 12 weeks. We can do the amniocentesis around 44. 50. But what is most important is counseling. What is practical that I have. When the child dies, they throw away all the papers. And then when you ask for the baby, paper, there is no paper. So I always tell them, while doing the counseling of this baby, that this baby is not going to survive. But please don't throw away all the papers. And they will invariably. বাচ্চাই যখন নেই, কার্ডও নেই,
The parents have also been asked for the.
এগুলো বলি।
It's
আমরা বলি না,
a.
So we have how you clinically differentiate from SMA, and there is another note: must test for Prader-Willi. Well, SMA.
SMA there was tongue fasciculation. But difficult to differentiate in newborn. In newborn, it is very difficult to see the tongue.
Actually, the diagnosis was explained by genetic study. It is not possible to differentiate a 6-day or 10-day congenital myopathy or SMA like that. Okay.
Jars in newborn.
Very difficult.
So we are moving on to our next presentation. It will be from our surgical department, life-threatening lung abscess, the surgical challenges by Dr. Krishnendu. Dr. Krishnendu Macho. রাখা যাবে সাইডে রাখো
Good afternoon, respected members of the association. Today, I will be talking about a challenge we face while dealing with a common diagnosis. So a 10-year-old boy weighing about 46 kilograms came to our OPD complaining of non-productive cough and respiratory distress associated with persistent high-grade fever since past 3 weeks. He was admitted outside with same complaints when they failed to subside after 1 week of treatment from local physician. So in that hospital, they did a chest X-ray, which revealed left-sided pleural effusion with shift of mediastinum to the right. Mediastinum and the trachea, we can see. We can clearly see on the left side that there is obliteration of both the costophrenic and the cardiophrenic angle and widening of the intercostal space on the left side. So they did a ultrasound guided pleural tap and sent the fluid for analysis, which revealed it to be exudative in nature. So in that hospital, they took the correct decision and put in a left-sided intercostal drain from which about 700 cc's of fluid came out. And immediately we can see, look, that there is reduction in the rightward shift of the mediastinum and there is expansion of the right hemithorax. If we can see closely, we can appreciate the upper margin of the left lung along with an air pocket in the apex. So clinically, the distress also subsided and he was maintaining SATs at minimal oxygen requirement. So culture came out to be positive for MSSA, and according to the sensitivity, they started him on IV meropenem and teicoplanin. But even after 12 days of admission, the fever did not subside. So they left that hospital against medical advice and came to our door. So when we examined him, he had a fever of 101 Fahrenheit and with mild pallor. There was no column movement in the drain and there was nil output since 24 hours. Trachea was shifted to the right and chest expansion was inadequate on the left side. Breath sounds were diminished and in the left upper region and was absent in the lower region. So we did a repeat chest X-ray. And look, there are well-defined opacification on the left side. Most probably there are two lobes of the left lung and there's air in the apical region. But don't worry, the drain is not in the heart, it's in the posterior mediastinum. So we did the contrast enhanced CT scan of the thorax. And we can see the classic findings of empyema thoracis. There's peripheral enhancement of parietal pleura. But what of the lung? There's collapse of both the lung. But luckily, the right lung appears to be healthy. We continued IV meropenem and teicoplanin and prepared him for OT. We did a left-sided thoracotomy and found the parietal pleura to be thick. It was complete. But what of the poor lung, poor underlying lung? It was completely white, it was collapsed, and the lower lobe had multiple tiny abscesses with features of necrosis. We decorticated the parietal pleura and the visceral pleura from the upper lobe and lingula, but we could not save the lower lobe. We had to do a lobectomy, but luckily we noted adequate expansion of the upper lobe. The specimen weighed about 400 grams, which is quite heavy for a lobe of a lobe. We electively ventilated him for 24 hours and he was shifted to ward within 48 hours. He had a spike of 102 degrees Fahrenheit, for which we added intravenous flucloxacillin, and there was no fever after that. We removed both the drains by the 7th post-operative day. The biopsy was suggestive of lung necrosis and empyema thoracis. The CBNAT was negative and culture was also negative. So he was afebrile since discharge, but mild cough still persisted. He came to our OPD for follow-up after 4 weeks of discharge, and we did a repeat chest X-ray, and we found residual air in the left lung. We advised a repeat contrast enhanced CT scan to assess the condition of the upper lobe of the left lung. So why are we faced with such challenges for a very common diagnosis? Probably due to uncommon complications, like in this case, necrosis of the lobe of the left lung. We must keep in mind that the successful management of empyema thoracis is a race against time because of the nature of this disease, and delayed referral is the most common difficulty that we face. And we must not forget, emphasis must be given to physiotherapy and caregivers must be trained prior to discharge. We can successfully overcome empyema thoracis, but we must remember that a stitch in time saves 9. Thank you.
I mean, how's the technique? Say, thoracotomy or I mean, most people, the ways have gone out of this drainage practice. Also, what's your opinion?
What you say is partially correct. Surgeons are not yet from what they process is the process of personal protocol, which is definitely guides for taking at the right form of the right time. The problem is that when they will take as day zero, day one. That's the problem. On that we have worked out that should work. I think this is first thing. That's can determine the help of basic brain and the
Favoritolytics.
neural thing. But after 14 days, doing that is often not adequate. We should do a stuffing, and after 4 weeks, the formal decoration times the vector is equal to
This patient came to us almost around third week, 15. We
Yeah.
received antibiotic for 12 days, and the disease process started around 4 days back. So on third week we received the patient.
In immunologic sometimes these cases. What I wanted to say is that drainage is really prolongs the hospital stay. Mortality is high. So one of the best option may be initially immunologics, and or it may be advanced, or it may be a meaning for of the four that I say. Tube drainage is very ancient and almost very obsolete.
Now
And
we have some question or discussion. So repeated CT might cause radiation injury. MRI chest might be helpful. And what about high resolution USG for follow up? So USG, MRI or CT, what is better? We regularly have a discussion in our seminar room nowadays in follow up cases. Now, some cases CT might be better, some cases MRI might be better, but here I think what the surgeons will prefer. What will you prefer?
High resolution USG is operator dependent.
No, among CT and MRI, what will you prefer if the patient comes to you on follow up? And what is the opinion of house? Because the patient had already done one CT one time. So are you going to do a CT second time, or are you going for MRI to reduce the radiation exposure?
So nowadays, radiologist has a low radiation CT. That is why it's not as much as the regular CT.
but still it is radiation, but many parents do not agree to that. But what I
But
feel
to-
that the advantage
visualize the
CT
pleura
is that you are trying to see a lymph node and interstitial lung disease. Other than that, all other cases, MRI is equally. Still, the surgeons believe that the CT of the abdomen is good for the appendicitis, but if you look at the abdomen, is equally good. MRI or CT. But in chest, for tuberculosis, you are trying to don't do MRI. So trying to look for a interstitial lung disease, don't do MRI. Which is,
But probably in this case,
the HRCT is a term which is now obsolete because all the cities are high resolution. We can do a CT or CECT. CT means CT, which is CT can contrast with contrast. So HRCT all are now high resolution.
so but in this case, probably yes, so bol.
one observation is that surgeons
Are always backward.
we are always backward.
Because they never accept a MRI and they will say,
No,
I
no,
want a CT for going for the
No, it's not like that. In general,
বললে তো হবে না
Yeah,
এখানে
what
আমার
I just said-
গুলো পড়ে গেল আপনি জানেন
our list is that. Listen, in general, we accept that an MR scan is more preferable than CT for soft analysis. And for analysis of
yeah
So,
I
there we agree.
see
Other
again,
thing is-
again, আমি
Other thing is, see, whole of Calcutta knows of it. someone said, "He's the last person I should go." The sergeant, listen, please.
It's an ever changing. Dr. Dada will agree.
Okay.
That at one time you say the for
It
brain
takes
hemorrhage, CD, but now the MRI, particular.
No, I will ask.
Is
the
this
whole
that? Huh? So it is also.
Last bit the whole
Ah.
the sergeants are more worse. That's why they get the idea. They know about the MRI. As they get taught, they become learned, they will do more MRI than
So-
They want the sergeant should also.
yeah. I agree.
But sir, probably for this case, when this patient is coming for follow-up, sorry, so this patient came very late. This patient came, there is no role of fibrinolysis. This patient came almost third week. But one thing I want to mention, this patient when is coming to us for follow-up, we want to see any pleural thickening or not. So probably MRI CT is better to see visualize the pleura rather than MRI. Probably, কারণ এর already একটা lobectomy is done, so there is only one lobe, and also if there is pleural thickening is developing or not, that is the important factor in follow-up. So probably CT will be better in this case, but we are nowadays moving towards MRI chest rather than CT chest.
That is the
Yes.
thing. That is another advantage, but we don't face problem because our MRI is here and pneumonia takes half the time of that of the conventional MRI.
The last exercise.
আমাদের মানবকে দেখেন না যে প্রতি হানি ঘুরে বেড়ায়।
Yeah,
So-
and then why the meropenem and decoplanin was started when the culture showed the flucloxacillin was added later, but why initially it should have
So the culture report came late. What they did a USG guided pleural tap, I think, and the patient came to the report after 5-6 days. So in between that, baby received meropenem antibiotic. Okay, so now we are moving on to our next case. I think we are running short of time. So acute encephalopathy, refractory hyponatremia, and hypertension. It will be presented by Dr. Gajalakshmi.
Good afternoon, everybody. Good afternoon, everybody. I am Dr. Gajalakshmi, and today I will be presenting a case of acute encephalopathy, refractory hyponatremia, and hypertension. A 7-month-old baby girl was admitted at a multi-speciality hospital with one episode of vomiting followed by convulsions. That was status epilepticus, which lasted for around 1.5 hours. The parents also gave a history of low-grade fever for 2 days, and they also complained that the child was less active for the past 2 days. Convulsions were aborted by midazolam. Initial stabilization was done. On examination, except for the postictal drowsiness and a few cracks on chest auscultation, there were no other significant findings. After initial workup, it was found that the child was encephalopathic and there was hyponatremia and hypertension. So along with the other supportive measures like anti-epileptics and antibiotics, the child was started on sodium correction and antihypertensives were added. As a part of hypertension, fundus examination was done, which was found to be normal. Further workup revealed that the CSF studies, including the autoimmune encephalitis panel, was normal. Echo as a part of hypertension was done, which was found to be normal. CT brain was within the normal limits. It was done to rule out any intracranial hemorrhage. And MRI brain, it showed mildly dilated ventricles with prominent subarachnoidal spaces. So the treatment received at the outside hospital were antibiotics, anti-epileptic, amlodipine and prazosin, 3% NaCl correction. Considering edema or autoimmune encephalitis, the child also received methylprednisolone and IV immunoglobulin. So the child was on 2 antihypertensives and repeated sodium correction was given. Still, the hyponatremia and hypertension persisted, and there was no improvement of the mentation of the child as such. So the child was referred to our institute. Initially, the baby was admitted in PICU for the continuous monitoring. Initial stabilization was done, sodium correction and blood pressure optimization was done. But the drowsiness and hypertension still persisted. There was persistent encephalopathy. What might be the reason? Is it due to hyponatremia or is it due to some underlying primary disease? So we started working upon the cause of hyponatremia. There was increased urinary sodium excretion and urinary osmolality was raised and serum osmolality was decreased. Other causes of hyponatremia like thyroid, glucocorticoid deficiency were also ruled out. A repeat MRI brain was done that did not show any significant changes. So this raised urinary sodium excretion and increased urinary osmolality, all this were kind of pointing towards SIADH. So we did other supportive investigations like fractional excretion of urates and phosphate, and then came to a provisional diagnosis of SIADH secondary to some primary disease. So we went ahead with the fluid restriction and tolvaptan at a dose of 6 mg per kg per day was started. And the hyponatremia gradually improved over days. So further, the hypertension persisted and we went ahead with the workup for hypertension. Urinary was normal, USG KUB and along with renal Doppler to rule out any renal parenchymal disease was done. That was found to be normal. MRE renal arteries to rule out renal stenosis was done. That did not show any significant changes. And serum aldosterone and plasma renin activity. That is as a part of primary hyperaldosteronism was also considered. That was also within the normal limits. So the child was still encephalopathic for almost 2 weeks, and there was persistent hypertension. So are we missing out? What are we dealing with? Are we missing out any hidden focus? Could it be a neuroendocrine tumor or any paraneoplastic syndrome? Yes. So we had done a battle of investigations already, and we were clueless. So we planned to do a PET CT of the whole body. And PET CT revealed that there was increased FDG uptake in bilateral mesial temporal cortices, thalami and basal ganglia, and brainstem, along with globally reduced metabolism in rest of the brain. So there was persistent encephalopathy, unexplained hypertension, MRI brain on 2 occasions were normal, diffuse FDG uptake in brain, and normal CSF autoimmune encephalitis panel. Yes, we came to a final diagnosis of seronegative autoimmune encephalitis. So the child has already received the injection methylprednisolone and IV immunoglobulins, which are the first line immunotherapy at the outside hospital. So we thought of second line immunotherapy, that is injection rituximab. Before that, we did the screening IgG levels and CD19 that was found to be normal. So we went ahead with injection rituximab. The mentation of the baby gradually improved over the next 7 days and the child was discharged. A repeat dose of rituximab was given after 15 days. Currently, the child is doing well. She's gaining weight. She's regaining her milestones. Tolvaptan is being tapered and minimal antihypertensive support. That is also being tapered. So my take-home message from this case are autoimmune encephalitis was thought to be rare. It is not so rare anymore. And this electrolytemia, especially hyponatremia and hypokalemia, may be an unusual presentation of autoimmune encephalitis. Antibody negative autoimmune encephalitis, they are more severe and they respond better to second line immunotherapy. And PET CT, this is an emerging new diagnostic tool and it is very sensitive and picks up changes earlier than MRI and CT. These are the few studies and case reports that was similar to our case. Thank you. Ma'am, there was diffuse increased uptake in the brainstem also. Maybe it is due to autonomic involvement. Ma'am,
We have similar cases and seronegative is very much very good response very quickly.
Ma'am, the now
Seronegatives are very much a response.
So,
The second diabetic response.
Antihypertension.
that is also even being tapered.
Follow.
So is it so that autoimmune encephalitis is increasing?
Sorry. Sir, it is being diagnosed.
Probably
Being
diagnosed. We are thinking more that
Yes.
we are sending the panel.
सामने से बोलो
We know that the LGA is manifested with hyponatremia and SID. in children it has not been treated as a series or a adults, but there are cases both. The youngest one is 7 years, youngest one is 6 years, I think. So this is a very unique case in such a small child, and how the child responded when you see the child now, child has responded magically to immune modulator. So it is a learning point that autoimmune difficulties may present
Even
in
in
primary
I
hypotension.
think at the same 6 months old, 7 months.
So,
Seven.
the PET CT picture, MRI was normal, autoimmune antibody panel was normal. The PET CT picture of the brain is specific for autoimmune encephalitis or
There's temporal, there is bilateral disturbance on the increased uptake. So in MRI, the structural changes see temporal lobe also in bigger than here. We see the external capsule inside. These are the areas which work. But
Did you
here,
go for the EEG and then
CG was done.
Initially, it was one slow centrifugation and then it's not.
It was showing like
The need has been reduced.
are this MPG uptake and basic? Global, almost global.
Only thing is that
yes, 6 months is very alive.
that is
We had
the
it.
normal
This child was actually an enigma. When this child came, it was actually an enigma, and actually there was a fight between me and Rajiv that who will be actually looking after the child, because we thought that it's a hyponatremia and all the stuff. So the nephrologist take over, and we had actually a big fight. And he said, no, nothing to do with the kidneys. I will take over.
There is a picture from pressure.
But I think that blood gas generation have been shown in the first line. Whatever the is a hypertension. It's all urine and the electricity
Potassium and pH is not
Potassium was there.
and pH মানে acidosis alkalosis. He has some sort of hypertension also not responding.
and in any case, pressure and the child so child responded and started therapy. And I responded. That as such it's not mentioned, but in the adult and adolescent 20 years, 2020, now there is a they are saying that up to 1 year to 2 years, it may persist. And this case also, whenever we are reducing the contact, the patient is having hypotension and so December 5 people should be had high. So there should be and even output theory it's so not restriction on does not right. Starting. And when we started for that stop the and now again we are doing stop. So now they almost stop.
So we have some questions, chat box. How do you follow up when you do again immune suppress depending on CD19? And another question, are the MRI finding characteristic of autoimmune encephalitis? So I would like to ask Joshadhara. No, MRI finding, not about the first question. When would you again immune suppress? Is,
6 months. Our protocol is CD19. We added the suppression part and then we do suppression now then we divide it first whether it is suppressing, suppression now maybe resistance is not working in that goes If it is suppressive but the patient is not improving, then it is taken as reductional failure. This is the protocol. So usually after 3 to 6 months, we repeat CD9.
But again, the patient is called up clinically, right? Clinically, this patient, this child has actually lost all the milestones, and the child has regained everything.
এখানে বলতে okay so
Can we go for PET scanning or MRI negative and antibody negative cases?
Yes, sir. We had almost 3 to 4 cases where acute febrile and coronavirus. MRI was very much non-specific, was normal. CSF, autoimmune antibiotic value was normal. Blood autoimmune antibiotic value was CSF, biochemical patterns and microbiology pattern was normal. So just given aceclopine and because of steroids and opinion from different neurologists of autoimmune antibiotics, give IV against steroids. So what three patients, you can remember 1 or 2. So all of 3 patients we have not given anything. Just given a metaprednisolone for the first patient.
probably
And
when
overall, the
PET CT was done for this patient, this was done to see for any focus. যখন কিছু পাওয়া যাচ্ছে না PET CT করে we try to look for a focus.
Especially in heart or cancer, it shows remarkable patterns of bilateral mesotemporal increase.
এর তো মেসেল টেম্পোরাল লোব ইনভলভ ছিল bilateral
Okay, specific কম করি মানে আমার প্র্যাকটিসটা যেমন এর আগে একটা G4 related disease. There was nothing found. We did a PET CT and then we found that
there is something behind the bladder.
একটা article আছে PO edit PET CT all cases and 8%. মানে যখন পুরো সব টেস্ট নেগেটিভ হয়ে গেছে স্পেশালি ইন PO
মানে একটা PO পেশেন্টের PET CT করে দেখা গেল যে অ্যাওর্টার মধ্যে এনহান্স করছে তারপর আলটিমেটলি অ্যাওর্টাইটিস ফিলিং। So PET CT is one of the investigations of choice for outward right. এটা আমি বলছি আমরা এখন আরো আগে করাই কোন দিকে তখন গেছিলাম।
So moving to our fifth case, unveiling the Rebecca, it will be presented by Subra Somodas.
Good afternoon, everyone. I am Dr. Subra Somodas. Veiled Rebecca is a famous statue of Salar Museum, which has been an enigma forever. Our case also has layers of mystery, which has been unveiled with for time. So this is a case history of a 3 years 4-month-old female child who originally presented with inability to walk for last 6 months, along with listlessness and decreased appetite. The child was actually having difficulty along with pain in walking from when the child was 2.5 years of age. Along with that, there was also deformity of lower limbs, which was started from the same period. For this, the child was admitted outside hospital, where by an orthopedician she was treated as a case of rickets. But in spite of treating, there was no improvement, and she was completely non-ambulatory from 2 years and 9 months of age. And for the child has admitted to our hospital at 3 years and 4 months of age with further evaluation and this complaint. On admission, the child was having tachycardia. There was pallor was present, and on head-to-toe examination, it was found that there was bilateral genu valgum was present, frontal bossing was present, widening of wrist is there, and rachitic rosary is there, along with hepatosplenomegaly. And on anthropometrically, it was seen that there is child is severely underweight and severely stunted. So on investigating, we found that the hemoglobin level is low, platelet count is low, hypokalemia is there, calcium phosphate level is normal, ALP is increased, and parathyroid level is increased. Direct Punct test was positive, and peripheral smear was showing features of normochromic normocytic RBCs, and the retic count was increased, but the X-ray was suggestive of rickets. So we found that there are symptoms of rickets are present. So we have to find the which disease caused these rickets. For that, we do some further investigations, which shows the urinary calcium creatine ratio is high,
And on USG abdomen, it shows the bilateral medullary nephrocalcinosis is there, which suggestive of increased calcium excretion through urine. Nephrocalcinosis is there, and urinary protein creatinine ratio is increased. Urinary anion gap was also increased, and blood gas analysis shows normal anion gap metabolic acidosis, which suspects as a distal renal tubular acidosis. For that, we done a confirmatory test, which is furosemide challenge test. That is pharmacologically induced metabolic acidosis, which was failed to reduce the urine pH level. That is that concluded it as a distal artery. Now, if we up to this picture, we found that the child having features of distal artery along with autoimmune hemolytic anemia and thrombocytopenia. Now, if we look at the etiology of distal renal tubular acidosis, among the etiologies of distal renal tubular acidosis, which fits among this clinical scenario, and that is the autoimmune disorders, which is SLE, Sjogren's syndrome, rheumatoid arthritis, like this. The other reasons is not fitting in this child's history, the investigations like this. So, if we look at the autoimmune disorders, rheumatoid arthritis is very less likely present as a features of rickets or the features the child has presented. So, if to confirm the other autoimmune disorders, we done some further investigation, which shows there is hypocomplement anemia. C3 level is low, C4 level is low. The ANA was positive, but surprisingly, the anti-DS DNA was negative. And to rather confirm, we done a renal biopsy. The renal biopsy reports was inconclusive. So, basically, what are we dealing with? If we say this is SLE, there are points in favor of SLE, there is points which are not favor of SLE. The autoimmune hemolytic anemia, thrombocytopenia, ANA is positive, and ANA is positive, and there is C3, C4 levels which are low, which points towards SLE, but which points against SLE, that is anti-DS negative, which is more specific for SLE, which is negative. Renal biopsy is inconclusive, and the age of presentation, that is not fitting for SLE. So for that for this confusion, we done another test, the extractable nucleic antigen antibody test panel, which shows there is strongly positive anti-Sjogren's syndrome A and anti-Sjogren's syndrome B, that is anti-Rho and anti-La antibody, which is strongly positive, and rest all are negative. And that concludes is as a case of Sjogren's syndrome. But surprisingly, which we seen that the eye checkup was normal. On eye checkup, it was the tear formation was normal, and there was no difficulty in swallowing. So the diagnosis was made as a Sjogren's syndrome presenting with distal renal tubular acidosis. Treatment was given with steroid, oral steroid at the rate of 1 milligram per kg per day, along with mycophenolate mofetil and hydroxychloroquine. And presently, the hemolytic anemia resolved, thrombocytopenia resolved, limb pain disappeared, and ambulatory without support for last 1 month, and so some sign of weight gain. And we had another case, 12-year-old female presented with recurrent episodes of limb pain with features of rickets, also preceding history of ITP, which was treated with course of steroids. And on investigation, we also found normal anion gap metabolic acidosis, positive urinary anion gap, and also in this case, the furosemide challenge test shows distal renal tubular artery. Urinary KUB shows the nephrocalcinosis features, and in this case also ANA was positive, anti-DS DNA was negative, and anti-Sjogren's syndrome A, that is anti-Rho, was positive. And renal biopsy was acute interstitial nephritis, and diagnosis made as Sjogren's syndrome with distal renal tubular acidosis. So from these two cases, we came to conclusion that although Sjogren's syndrome is characteristically associated with symptoms of dry eyes and mouth, extragranular renal manifestations are not uncommon presentation. Sjogren's syndrome is actually rare in childhood age, but among the Sjogren's syndrome, the common features are Zika symptoms, which is also rare in some cases. So most common renal manifestation is tubulointestinal nephritis, which can manifest as renal tubular acidosis. And individual with idiopathic renal tubular acidosis should be screened for Sjogren's syndrome. Thank you. Any question for the judges? Sir, ma'am. Steroid, oral steroid, mycophenolate mofetil, and hydroxychloroquine. Actually, the RTA was resolved because the pH was getting normal, 7.3 from 7.1 to 7.3. The actually the nephrocalcinosis is a questionable matter whether it will be reversible or irreversible. It have to be actually yes. It was.
So, salivary gland biopsy, we have a similar case later evolved to SLE. Did you do renal biopsy for SLE confirmation and pediatric? Common-
It was inconclusive.
So prob-
In first case, it was inconclusive. In second case, it was tubular interstitial nephritis.
Pediatric cases, commonest presentation is recurrent parotiditis.
We have a joint.
Okay. So, next presentation by Dr. Alisha.
Question answer here. And this book of no question.
What is the incidence? It again. So our next presentation will be by Dr. Alisha Kujur. Much ado about hormones. And we have another presentation of another case after that.
Good afternoon, everyone. I'm Alisha Kujur, a second-year resident of Institute of Child Health, and today I'll be presenting a series of pediatric endocrinology cases. Starting with a case 1, here we have a 3-year-old boy who has come to us with a complaint of difficulty in walking since last 1.5 years. Repeated orthopedic opinion were taken, but they were of no help. And for the last 3 months, he's even unable to stand. So we performed a series of radiographs of the limbs, in which you can see in the first image that there is metaphyseal cupping and splaying. In the second image, we can see that there's metaphyseal widening. And in the third image, we can see that the cortex is irregular and it is thickened and appears more whitish. That is, it appears more sclerotic. In these 2 images, the arrows have been pointing at the hyperlucency of the bony matrix, which points towards osteopenia. So is it a metaphyseal dysplasia or rickets? Next, we went for the lab parameters, in which we can see that the serum calcium level is normal, phosphate is decreased, alkaline phosphatase is increased, and 25 hydroxy vitamin D3 and parathyroid hormone are of the normal range. So next, we performed a ratio between tubular maximum reabsorption rate of phosphate and glomerular filtration rate, which came to be low. So from this, we can see that some kind of phosphate wasting is occurring in the body. So a provisional diagnosis here becomes hypophosphatemic rickets. On physical examination of the child, we can see that there's multiple hyperpigmented skin lesions in various parts of the body. So on one hand, we are having this picture of hypophosphatemic rickets along with the skin lesions. So a differential diagnosis in this case comes to the conditions which are associated with FGO23 gene mutations, which are hypophosphatemic rickets associated with epidermal nevus syndrome and cutaneous skeletal hypophosphatemia syndrome. Next, we have planned on to do a genetic test and to check for FGO23 blood level in this patient. So a take-home message from this case is cutaneous markers aids in arriving at a proper diagnosis. For the second case, we have a 3-year-old girl who has been brought to us by her parents with a complaint that she has not been attaining adequate height as per her peers. So we performed a basic soft stature workup, which included radiographs for the bone age, routine blood investigations, blood gas analysis, blood glucose, cilia screening, thyroid function tests, and urine analysis. All this workup came to be normal. So next we checked for the growth hormone stimulation test, in which the peak growth hormone came to be low. We also checked for the serum insulin growth like factor 1, whose value came to be low as well. So we can get a provisional diagnosis that there is growth hormone deficiency, and as a part of the treatment, we started her a growth hormone therapy. As we can see from this growth chart, that as the growth hormone was started, and there was subsequent increase in height of the child. So on follow-up, we can see that there was good growth hormone response. The thyroid function tests were normal, but the blood glucose level came to be 50. We then told her to check for fasting self-monitored blood glucose levels, and most of the time it came to be less than 60, but the child was asymptomatic. So we checked for the serum cortisol level, which came to be low. We also did ACTH stimulation test, and the response was appropriate. So a confusion of primary adrenal insufficiency was ruled out. So with all these confusions, next we performed a genetic test in which we found out that she was suffering from a condition known as combined cerebellar and peripheral ataxia with hearing loss and diabetes mellitus, in which there was homozygous mutation for the gene DNA-JC3. On retrospective analysis, we found out that there was history of frequent fall during walking. On audiology assessment, mild bilateral sensory hearing loss was found. But why was there hypoglycemia and not hyperglycemia? So we come to this condition known as hyperinsulinomic hypoglycemia, which occurs due to biallelic mutations in the gene DNA-JC3. So a study was performed in which the children who were suffering from these gene defects were taken into, and they were divided into two groups, one having a neurological phenotype, other having the endocrine phenotype. In the endocrine phenotype, all the children who had severe early onset growth failure due to growth hormone deficiency and hypothyroidism of central origin were grouped together. And in the neurological phenotype, we had those who had early onset sensory neural hearing loss, which was discovered under 5 to 6 years of age, and neurodegeneration of central and peripheral nervous system in the first 2 decades of life. In both these groups, we found out that around 2 years of age, due to beta cell dysfunction, there was hyperinsulinomic hypoglycemia, which later on in the second decade of life evolved into diabetes with insulin deficiency, which occurred probably due to beta cell loss. So coming to our case, the fasting blood glucose is 52 and the serum insulin is a bit raised as can be compared from the chart given on the critical sample. So with a diagnosis of hyperinsulinomic hypoglycemia, we started her on low-dose dioxazide. So a take-home message from this case is genetic test can be used as a conclusive investigation in cases with questionable diagnosis. For a third case, here we have a 9-year-old girl who is a known patient of type 1 diabetes mellitus, which was detected at the age of 6 years. She is on basal bolus insulin regimen and has good glycemic control. She suddenly started having recurrent hypoglycemic episodes, and so the insulin dose was reduced. But even on very minimal doses of insulin, there was recurrent hypoglycemia, and she even complained of generalized weakness. On examination of the child, we can see that there's hyperpigmentation of the knuckles and the lower lips. Serum cortisol level was checked, which came to be low, and serum ACTH level was found to be very high. So we come to a diagnosis of primary adrenal insufficiency in a known patient of type 1 diabetes mellitus. So as a part of the treatment, we started her on hydrocortisone at 8 mg per meter square per day. On follow-up, we can see that the hyperpigmentation has resolved. So a take-home message from this case is, we should always check for adrenal insufficiency in a patient of type 1 diabetes mellitus who is having sudden onset unexplained hypoglycemic episodes. That is, in a patient suffering from any autoimmune condition, we should always screen for other autoimmune disorders as well. Thank you. So carpenter syndrome. Skimmed it is autoimmune thyroiditis along with type 1 diabetes mellitus. Thyroiditis along with type 1 diabetes mellitus. Carpenter में sir there is type 1 diabetes mellitus along with adrenal insufficiency.
Yes, persevere was having darkening of this around the eyes and which the family say that uncle chole geche সেই কাঁদতে কাঁদতে এরকম. So at that point, because the diabetes was already being treated and darkening around the eyes, and also then looking at the skin, we thought that it is adrenal insufficiency. Then we check for the insufficiency, and it turned out to be adrenal insufficiency.
So any other question, or we'll move on to our last case. This is from PICU, vasopressor refractory fulminant shock.
Good afternoon, everyone. I am Dr. Orchishman Mundal. Today my topic of discussion is the shock that really shocked all. Here is a 4 years old girl patient presented with history of fever for last 2 days associated with blanching rash all over the body with loose stool for 1 day. She was also drowsy at presentation. On examination, when the patient presented at the ER, the patient was in a shock state. There was no peripheral pulses was palpable. The BP was not recordable. The patient was tachycardic and tachypnea was also present. The EPG was done. It shows that it is a severe metabolic acidosis. In the initial management, we managed the airway and 100% FiO2 oxygen was given. Now we secured the cannula and initial fluid resuscitation was given. Due to low CBG, we corrected the CBG and we shifted the PICU, shifted the patient to the PICU. So these are the differential diagnosis. This may be a case of the septic shock, dengue shock syndrome, or toxic shock syndrome. Due to loose stool, this may be a hypovolemic shock or cardiogenic shock. Our management in the PICU, we started with adrenaline and noradrenaline. USC guided fluid resuscitation was given. After sending all the blood cultures, IV antibiotic meropenem and teicoplanin was given, but the patient was not improved. So the patient was catecholamine refractory, was in catecholamine refractory shock, and the sensorium was very bad. So we intubated the patient and mechanically ventilated. Then also after giving the adrenaline and non-adrenaline, the situation is not changed. The BP was still very low, so we added the vasopressin, and injection hydrocortisone was also added. In the meantime, the blood investigation came. It shows neutrophilic leukocytosis is there. The sepsis screening was positive, and the coagulation profile was deranged, and the renal function test was also deranged. We did the echo to rule out the cardiogenic shock, but it was normal. The dengue in NS1, IgG, IgM was also negative. The chest X-ray shows the findings of ARDS. In next 2 hours, we managed the patient with adrenaline, non-adrenaline vasopressin, and also adequate fluid resuscitation was given. But the patient was in refractory vasoplesic shock. So keeping it in our mind that it may be a case of toxic shock syndrome, we give IV clindamycin and intravenous IVIG was given. This was the picture at after 5 hours in the PICU. The patient was still in high ventilatory settings. The refractory vasoplesic shock was still continued. The urine output was not maintaining. The arterial lactate was also very high, and superior vena cava oxygen saturation was not maintaining. The BP was also in the lower side. The BP was 71/28, and now we don't have so much option in our hand. So we tried a novel therapy with IV methylene blue. We started IV methylene blue with 2 mg per kg. IV bolus was given. Then 0.3 mg per kg per hour IV methylene blue infusion was started. Then it was increased to 1 mg per kg per hour, and there was a dramatic response from IV methylene blue. This is the around after 2 hours, the BP was more than 50th percentile, and the BP was 93/56 after giving the methylene blue. This is the methylene blue expression in the urine and the color changes of the urine. In next 24 hours, the ionotropes infusion gradually tapered, but there was blackish discoloration of the toes and fingers started. We did Doppler study of the bilateral lower limb. The study showed that there was no blood flow below the left popliteal artery. We started unfractionated heparin urgently, and also GTN was started. But the blackish discoloration gradually increases. This is the color changes of the lower limb. In the next 72 hours, all the ionotropes has been tapered and ionotropes were omitted. The inflammatory markers started coming down, and after 72 hours, the X-ray of the lung shows that the ARDS improved gradually. The sensorium of the patient also improved. After 10 days of the PICU stage, the patient was extubated. But the left lower limb was black in color, and the left lower limb was cold and pulseless. We take the opinion from the orthopedic and plastic surgeon. They told that the limb is not salvageable. So the below knee amputation of the left lower limb was done. These are some literature that shows that the importance of giving the methylene blue in case of refractory septic shock. So our take-home message is that the septic shock is an emergency with high mortality rate even in best centers. The early recognition and the immediate treatment is the key to good outcome. We can use the methylene blue in case of refractory vasospastic shock. Thank you.
So, can I just comment? Just this, that patient thyroid or that is called the type. Yes, and that is it.
So
septic shock. Did you have any look for that culture body fever?
the culture was negative.
So the septic shock, and what is the saturation level in the when you decided to be?
Methylene blue, that was the.
So this is, I think, no, this is before starting the study.
What is the situation?
This is with maximum support.
Actually, methylene blue is the bolus dose. Whenever you use the bolus, after giving the bolus, the saturation level. After the bolus is over, so in the people giving methylene blue can see that we are in a intracranial vasospastic shock at diastolic blood pressure of only 20. And after 28 also. And after a few hours of methylene blue, for the diastolic limb is 56. Saturation came down from 95. So that when the patient was severely blue, saturation was coming to 86.
After studying the things became,
No,
so it's not
Otherwise, they just keep going.
yes,
this blackening started. This core perfusion from blackening started very early, within 6 to 7 hours. Within 3 to 6 to 7 hours of onset, it started blackening. So most of these patients having some underlying endothelial. We have seen few of the cases when our minimal dose of minimal septic shock that presenting with the blackening of the leaves. All the leaves have been salvaged, but the left leg was
and some
What is actually nitric oxide and molecular level?
there is a question regarding
Oh,
there is a question.
we have not done that.
No. This is related to this case. This case, the 252.
Not APLA can be there. A lot of secondary APLA can be there. It's sepsis. Now sepsis is a known cause of secondary APLA. Never say that APLA is not. The APLA is a second sepsis is a known cause of secondary. But in APLA there are thrombosis. We know the pathology. But this child has thrombosis. There is no thrombosis. All the things are have been done. Only the no thrombosis was there. And the pathology report deals only with the gangrene. Because we have sent the there is not a thrombus, then how can there be a gangrene? So because there is widespread obstruction. This is the endothelopathy on top of that, we are giving that's why we have given a GTN. We don't even know the histology report of the gangrene. Gangrene is a gangrene. It's not a gangrene. So send a gangrenous leaf. Whatever may be the cause of the gangrene, infection or anything, the report will be the gangrene. It should be the gangrene.
So we are coming towards the end. So these are the cases we all have. So
Thank you. Wonderful cases. We've learned a lot, and variety of cases are very well, executed and well planned and to the diagnosis and management. I think all has a very excellent last patient had only. So much, and but everyone has done it very nice. Everyone is very up to the mark. But we have to give someone first prize and second prize as a custom. So first prize goes to Gaza Lexi.
The work was done over months together, and when she presented in a very caption,
and Alisha and Tishman.
Thank you.